I'm Susanna Proudman. I'm a rheumatologist at the Royal Adelaide Hospital, and this presentation will cover some key messages about living with rheumatoid arthritis, from early diagnosis to ongoing management. Rheumatoid arthritis is a chronic autoimmune disease characterised by inflammation in the joints and on occasion in other organs in the body. Untreated, it leads to irreversible joint damage, deformity and disability due to the hallmark lesion of the disease, the erosion, which is essentially a hole in the bone caused by the inflammation. Rheumatoid arthritis affects approximately 1% of the population, occurs worldwide and targets women 3 times more commonly than men. It affects almost all joints of the body, although the hands, wrist and feet are typically involved in most patients. Risk factors for developing the disease include genetic factors, age, and lifestyle factors such as smoking, soft drinks, obesity, and gum disease. But there have been significant advances in treatment, including improvements in the way disease-modifying anti-rheumatic drugs, or DMARDs, you'll be hearing more about them later, are used in the clinic, as well as the development of new DMARDs, to the extent that some of the treatments that were commonplace in the past, such as joint replacement surgery, are rarely required these days. Nonetheless, life expectancy is still somewhat reduced, mostly due to premature cardiovascular disease, such as heart attacks and strokes, rather than due to the disease itself or its treatment, meaning that it's important to keep a strong focus on controlling risk factors for these complications too. The dramatic changes in the treatment of RA in the past 2 decades have markedly reduced joint damage, leading to significant improvements in function and quality of life for many patients. We now know much more about why people get RA and how to diagnose it early. And therapy has certainly improved, as mentioned. And of course, each step of this roadmap is underpinned by non-drug therapies and things patients can do to improve the outcome of their RA. Now, after receiving a new diagnosis of rheumatoid arthritis, one of the very first questions that often comes to mind is, why did I get this disease? Although the exact trigger in any one individual is unknown, environmental factors such as smoking and maybe infections are thought to drive inflammation, usually in somebody who is already at increased risk due to the genes they share with a family member, usually with rheumatoid arthritis or maybe another autoimmune disease. In rheumatoid arthritis, this leads to ACPA antibodies, also known as anti-citrullinated peptide antibodies. I'll be talking more about them in a minute too, which probably also contribute to the joint inflammation. We now know that this happens in the first instance in mucosal sites, such as in the lungs of smokers, in the gums of people with periodontal gum disease, and probably in the gut before spreading to involve the joints. Smoking is one of the strongest risk factors for rheumatoid arthritis. We certainly know that it attracts immune cells to the lungs and increases inflammatory cytokines, including those that are found in the joints of people with RA, such as tumor necrosis factor, or TNF, and interleukin-6, or IL-6. Importantly, smoking leads to increased citrullination of proteins, which tells us a bit about why rheumatoid arthritis develops, at least in some people. This is the process by which smoking stimulates an enzyme called PAD to change some of the proteins in your body so that your immune system considers these proteins to be foreign and mounts an immune attack on them, leading to the production of these ACPA antibodies I mentioned before. These are found in approximately 50% of people with RA, sometimes years before they get symptoms, but really not in any other disease. The process of citrullination is thought to explain why people with periodontal gum disease are more likely to develop RA and vice versa. People with gum disease are very likely to carry a bacterium called Porphyromonas gingivalis, which carries the PAD enzyme that induces citrullination of proteins and the production of ACPA antibodies. It's quite likely that RA and periodontal gum disease may in fact have a common cause. Advances in diagnosis of rheumatoid arthritis include an update to the classification criteria for this disease to take into account the importance of ACPA. People with inflammation in multiple joints, a positive ACPA or rheumatoid factor, increased inflammatory markers such as C-reactive protein or ESR for more than 6 weeks with no other explanation are very likely to have rheumatoid arthritis. Diagnosis is also aided by being able to see the inflammation within the joints themselves. In this ultrasound image of a joint, we can see the thickening of the synovial lining due to the inflammation that we call synovitis. The red areas are a power Doppler signal that mark increased blood flow, which indicates more active inflammation within the synovial lining. Even more convincing is being able to see the hallmark of rheumatoid arthritis, erosions within the joints, as outlined on this hand MRI scan. Every so often, experts in rheumatology get together to update the guidelines for best practice management of rheumatoid arthritis. This year, the American College of Rheumatology published the latest guidelines, which are publicly available online. The primary aim of such guidelines are to outline current best practice for using DMARDs to control rheumatoid arthritis before joint damage occurs. The goal of treatment is remission, a state where the disease is as good as gone, and that we can measure with disease activity scores such as the DAS28 that use counts of swollen and tender joint counts, blood tests such as the ESR or CRP, and patient-reported outcomes, usually with questionnaires. The key to treatment success has been the use of DMARDs early in the disease, ideally within 3 months of symptom onset. This is usually with the well-known conventional synthetic DMARD methotrexate, often in combination with other DMARDs, and using the DAS28 or similar score to guide dosage adjustments of the medications and or addition of new drugs until the target, a low disease activity state, is reached. This is called the treat to target approach. Those who still have active disease above the target after a 6-month trial of at least 2 conventional synthetic DMARDs, including 3 months of methotrexate at 20 milligrams per week if tolerated, may be eligible for PBS subsidised biologic DMARDs in Australia. These are some of the newer drugs that have been available in the last decade or so. This study demonstrates the value of starting treatment early. The only predictor of remission in patients receiving treatment using the treat to target approach was treatment within 12 weeks of symptom onset, which was associated with fewer patients needing biologic DMARDs and more patients being free of disability at the 12-month mark. Since the 1980s, methotrexate has been the cornerstone of RA treatment with well-established efficacy and safety profiles. Now, given weekly, higher doses than were used in the past are now recommended. A number of strategies are used to maximise the safety of methotrexate, such as baseline tests for latent infections, the use of folic acid, regular blood tests to screen for side effects, sensible alcohol usage within recommended guidelines, and the avoidance of use in pregnancy and breastfeeding. Although methotrexate is cost-effective and safe, it still has a bit of an image problem as it's used in cancer treatments in much higher doses than used in rheumatoid arthritis. But it's important to remember that methotrexate is not considered to be chemotherapy at lower doses because there are different mechanisms of action when used in a low dose versus high doses. People undergoing treatment with low-dose methotrexate and the healthcare professionals who help them with this do not need to use special precautions when handling methotrexate. Sometimes oral methotrexate is poorly tolerated or there is an inadequate response. But because this is often because the bioavailability, meaning the proportion of the drug which is available in the system, is highly variable, ranging from 20 up to 100% due to genetic differences between individuals. So if oral treatment fails due to intolerability or inadequate response, the patient may be rescued by switching to subcutaneous delivery of methotrexate by injection. There are now pre-filled syringes of methotrexate readily available from your pharmacy by prescription. Methotrexate information sheets and about information sheets about all the drugs used in rheumatology are available on the Australian Rheumatology Association website at the link on the screen, and all rheumatologists recommend their patients to review these if they have any questions about their disease and its treatment. Another drug class that's commonly used in the early stages of rheumatoid arthritis treatment are the glucocorticoids such as prednisolone and injections, which result in rapid improvement in comfort and function, so are useful when waiting for a new DMARD to take effect and to treat flares of the disease. We have a preference for injections, for example, into joints rather than tablets, which usually mean patients take much more of the drug and therefore experience inevitable unwanted side effects such as osteoporosis and fractures, an increased risk of infection and diabetes. Turning now to the biologic or BDMARDs, this schema shows where DMARDs target the inflammatory cascade in a rheumatoid joint. This runs in a clockwise direction from the upper left-hand corner where it says inciting antigen, which may well be one of the triggers of the disease. Conventional synthetic DMARDs such as methotrexate and leflunomide act early in the pathway, shown at the top, inhibiting T-cell proliferation and production of antibodies such as ACPA by B cells, while the newer biologic DMARDs act more specifically further down the pathway, targeting the various cytokine molecules such as TNF or IL-6 that cause tissue damage. Many of these, such as the TNF inhibitors, and you can see the list of 7 different ones on the screen, have been used for nearly 2 decades now. A newer class of DMARDs has become available in the last few years and are now widely used in Australia. These are the Janus kinase or JAK inhibitors, which are referred to as targeted synthetic DMARDs because they're small molecules and can be taken by mouth. The enzymes that they inhibit, the Janus kinase family of enzymes, are associated with cytokine receptors on the surface of cells, which are involved in inflammatory and immune responses. Inhibiting these enzymes can reduce immune responses, such as those in rheumatoid arthritis. And so far in Australia, there are 3 different JAK inhibitors available, each of which has a slightly different inhibitory profile for different enzymes. Of course, like all biologic DMARDs and other DMARDs, Janus kinase inhibitors alter the immune response. And in this particular case, they may increase the risk of serious infections, thrombosis and shingles, and possibly cancer. BDMARDs and the targeted synthetic DMARDs are used with there are a number of considerations that need to be taken into account. Firstly, being high-cost drugs at about $15,000 to $20,000 per year per patient, a written application to Medicare Australia and meeting eligibility criteria need to be met. These include multiple swollen and tender joints and elevated inflammatory markers. These drugs should not be used by patients with tuberculosis, severe infections or active malignancy, multiple sclerosis or heart failure, and they should be discontinued if a serious infection develops. Biosimilars are now available. These are somewhat cheaper, but they're not identical to the originator drug. Switching between them is not recommended due to the theoretical risk of triggering autoimmune complications. So it's important to be sure that you check with your pharmacist that you're receiving the same drug each time. So there's been a renewed focus on the need for vaccination when people take DMARDs, as they can suppress the response to infection. Certainly when you're taking conventional synthetic DMARDs or biologic DMARDs, a number of vaccines are safe, such as the pneumococcal vaccine, the influenza vaccine, hepatitis B vaccines in people who have risk factors, and the cervical cancer vaccine. In people who are taking conventional synthetic DMARDs such as methotrexate, particularly if they're more than 50 years of age, the shingles vaccine, which is actually a live attenuated vaccine, can be used, but is probably not safe during the use of biologic DMARDs, although this is a desirable vaccine, and so ideally should be given 2 weeks before starting the biological DMARDs, and particularly the JAK inhibitors such as tofacitinib. When actually taking a biological DMARD, therefore it's unwise to take the shingles vaccine, but there is a new shingles vaccine which is not a live attenuated vaccine that is approved by the TGA but not yet available on the PBS, which may be used in the future. So obviously another current issue of concern relates to COVID, and vaccination is even more imperative in people with rheumatoid arthritis. We have learnt a little more about rheumatoid diseases and COVID, such as the risk factors associated with severe COVID-19 outcomes, including age over 65 years of male sex, and pre-existing comorbidities such as hypertension and cardiovascular and respiratory diseases. Immunocompromised individuals are at increased risk of infection, and that includes rheumatoid arthritis. And COVID-19 is more prevalent in those with the connective tissue diseases, however, than in those with chronic rheumatoid arthritis, particularly with those with pre-existing interstitial lung disease, although this does occur from time to time in people with rheumatoid arthritis. ILD is associated with a more severe pneumonia too, and hence a worse outcome. Interestingly, some of the drugs used for rheumatoid arthritis, like corticosteroids, tocilizumab, and baricitinib, are being used to treat COVID. So another current issue related to COVID is the global shortage as a result of this due to tocilizumab. This is a screenshot of the Australian Rheumatology Association website, which has useful information for patients and pharmacists about how to obtain some of the scarce stocks of the subcutaneous formulation of tocilizumab. The intravenous formulation is almost impossible to procure now, so your options for DMARDs should be discussed with your rheumatologist. This is the Arthritis Australia website, which has a link to a recent ARA and Arthritis Australia webinar on this topic. All DMARDs, including the newer biologic DMARDs, while effective in many patients, carry a risk of intolerance and even serious toxicity such as infection, as mentioned. So in addition, not all patients actually achieve remission. So are there any non-drug options that can enhance the efficacy of DMARDs without increasing toxicity? Firstly, never underestimate the importance of self-management strategies. Indeed, this is the publicly available European recommendations for the implementation of self-management strategies in patients with inflammatory arthritis like RA. These are listed here and include taking an active role in your healthcare team, the importance of patient education and self-management resources, such as you can obtain through Arthritis South Australia. And it also highlights the value of digital resources, for rheumatoid arthritis. So it's worth mentioning that Arthritis Australia has developed a new online support program for RA called MyRA, which, with a bit of information from you about your journey with RA, can provide you with education resources tailored to your needs. Now, some risk factors for developing rheumatoid arthritis, such as age, gender, and genetic risk, can't be changed, but some lifestyle factors that are associated with RA may be modifiable and may therefore also be useful in modifying response to therapy. These include smoking, obesity, and diet. And we know that diets rich in omega-3 fatty acids, most commonly found in fish, have been associated with reduced risk of RA, even in people with other risk factors, being shown to reduce joint pain and swelling and the need for non-steroidal anti-inflammatory drugs. All patients at the Royal Adelaide Hospital Early Rheumatoid Arthritis Clinic are recommended to take an anti-inflammatory dose of fish oil, and we wanted to know whether these modifiable lifestyle factors, including increasing omega-3 intake with fish oil, are associated with the response to therapy in rheumatoid arthritis in the early stages. So in 311 patients with early RA, we examined whether any risk factors were associated with their response to DMARDs. Many of these patients already had recognised risk factors for RA and for a worse outcome, such as ACPA, genetic risk factors or obesity, and 50% had a history of smoking. As an indication of dietary fish oil intake, we can measure the levels of one of the omega-3 fats, eicosapentaenoic acid or EPA, in the blood. Now, not everybody takes fish oil consistently, so this resulted in a spread of blood levels of EPA seen in the graph on the right. We found that the strongest predictor of RA remission at 1 year was the blood level of EPA, so that those who had the higher fish oil intake, the higher level of EPA, had the highest chance of being in remission. On the other hand, smoking in people, particularly in those who were obese and still smoking, had the lowest likelihood of going into remission. So this is the treat to target protocol that we use at the Royal Adelaide Hospital. It's similar to that might be used elsewhere. Here we prescribe patients triple therapy with methotrexate as well as sulfasalazine and hydroxychloroquine, the so-called triple therapy regimen. Disease activity is assessed every 3 to 6 weeks, and the doses are increased until the target low disease activity level is achieved. Once maximal tolerated doses of triple therapy are reached, leflunomide is added, and this really means that the triple therapy has failed. So to confirm that enriching the diet with omega-3 fatty acids using fish oil increases the chance of a good response to therapy, meaning they didn't need to use leflunomide as well, we undertook a randomized control trial of the anti-inflammatory dose of fish oil against the background of this treatment algorithm. And we found that the rate of progression to leflunomide, failure of triple therapy, was significantly different, with the patients in the control group being 3 times more likely to need a leflunomide to be added to their treatment regimen. Also, the rate of achieving remission in the fish oil group was twice that of the control group, even though they took fewer DMARDs. So in summary, diet, body mass index and smoking are potentially modifiable factors that have been shown to be associated with a response to drug treatment in early rheumatoid arthritis. Increasing omega-3 levels with fish oil reduces the number of DMARDs needed while increasing the chance of disease remission. So lifestyle changes such as weight loss and smoking cessation and taking fish oil may improve outcomes for people with rheumatoid arthritis. So what does the future hold for people with rheumatoid arthritis? I guess what we'd really like to see is a cure, and even before that, be able to prevent rheumatoid arthritis. Cure means that continued remission after withdrawal of DMARDs occurs. The BEST study is one of many that have actually looked at withdrawal of DMARDs once patients have achieved remission. And it highlights a couple of key points. Certainly it's possible to do this if patients have been in sustained remission for a period of time. And they found that after 4 years off drug, only 13% of people were actually in drug-free remission. And of those who had actually achieved drug-free remission at some point, more than a third of them had to have their treatment reinstated because their disease activity score had risen. And actually about anything up to a third of the patients who weren't taking the drugs had a rise in their sharp X-ray scores at the 4-year mark, indicating that joint damage still persisted even in patients who didn't appear to have active disease. So it's not clearly possible to have drug-free remission or cure, but in some patients it may be possible to gradually withdraw DMARDs if they remain in remission for a long period of time, and there's a plan to increase therapy again if symptoms return. And what about prevention? An Australian rheumatologist, Professor Ranjani Thomas, has been working on treating people with risk factors for rheumatoid arthritis for some time now to find out how we could actually do this. So she's identified people with so-called pre-rheumatoid arthritis. So these are high-risk individuals with a family history of RA, who've had a history of smoking and are now ACPA positive and are starting to develop some symptoms. And they've identified 11 modifiable risk factors, which together could reduce the risk of developing rheumatoid arthritis by 40%. And these include stopping smoking, maintaining a healthy weight, increasing leisure time and physical activity, and maintaining good dental hygiene, omega-3 fats and reducing sugar intake, moderate levels of alcohol, and avoiding exposure to other risk factors such as silica, and ensuring that your vitamin D level is replete may in fact prevent rheumatoid arthritis and keep people off the roadmap for rheumatoid arthritis right from the very beginning. She's also been working on a personalised immunotherapy regimen using the patient's own immune cells, but we're yet to see whether it is possible to prevent rheumatoid arthritis with this strategy one day. So thank you very much for your attention.